Today, I welcome everybody. I welcome everybody to this August gathering. We will enjoy a feast of academic feast. Actually, we will be discussing three cases. There is not much to say in the welcome address. It is only customary and 30 minutes of glory. I welcome everybody. Please enjoy the feast. The first case will be moderated by Dr. Prasanna Rai. I now uh, I now call upon Dr. Prasanna Rai to present the first case and discuss it. Thank you very much.
Thank you, sir. Good evening to all my respected colleagues and my dear seniors. Now, I request Dr. Shankar De to start screen sharing. He is going to present his collection of cases on first trimester cardiac anomalies. Dr. Shankar De, please unmute yourself and screen share. Dr. Shankar De, please screen share.
Okay. Can you see my slides?
Yeah, please go full screen. Please start.
Okay, thank you, Prasanna, for introducing me. And good evening, my respected seniors and all my dear colleagues. I am Dr. Shankar De. Today, I am going to present a collection of cardiac anomaly cases in the first trimester diagnosed at our center. I sincerely thank SFM for giving us the opportunity to show our cases on this great platform. Examination of the fetal heart in the first trimester focuses in general on the evolution of situs, the fourth chamber, and the great vessels in order to confirm normal anatomy and to rule out complex congenital heart defects. Due to smallness of cardiac structures, its visualization requires high resolution grayscale and color Doppler with a combined transabdominal and transvaginal approach. Actually, there are four common indirect signs of the cardiac anomalies in the first trimester that can be used as hints, like increased nuclear translucency, abnormal ductus venosus, tricuspid regurgitation, and abnormal cardiac axis. The cardiac axis is very important here because it's found to be abnormal in 75% of cases with cardiac anomalies. And we need to visualize four essential planes. That is the axial view of upper abdomen, the fourth chamber view in grayscale, the fourth chamber view in colored Doppler, and the 3BT view in colored Doppler. All these provides enough information to rule out most of the major cardiac abnormalities. Here I am presenting a case. You can see the reversal flow in the tricuspid valve, and so this is a tricuspid regurgitation I am showing, along with reversal of A wave in the DV. These are the markers of the cardiac anomaly, also the markers of aneuploidy. So first we come to the abnormalities of the fourth chamber, where there is a problem in the ventricular filling. You can see the patterns. We have to recognize the patterns. First is the normal pattern and others are the abnormal patterns. We have to recognize all of them. So now I am present a case of hypoglossal left heart syndrome. In the grayscale fourth chamber, you can see the left ventricle appears very small, and also you can notice the single outflow in the 3BT because it involves significant underdevelopment of the left ventricle and the left ventricular outflow tract. Here you can compare with the normal in the lower pen, and in the upper pen you can see the very small left ventricle, and color Doppler shows the absence of flow through the left ventricle. Only single inflow is there and single outflow instead of two normal outflows. Similarly, we can see here the right chamber of the heart is small. There's the right ventricle is small, and the left ventricle is in a normal size, and there is a small VSD there. So what you can see is absence of the right atrioventricular connection, resulting in no flow between the right atrium and the right ventricle through tricuspid valve. The right ventricle is therefore very small in size, and a VSD is present there. Here gives the diagnosis of the tricuspid atresia with obligatory VSD. Another case I want to show is the AVSD. that is atrioventricular septal defect. You can see the linear insertion of the AV valves and a defect in the middle of the heart during the diastolic phase in the 4-chamber grayscale. Color Doppler reveals the classic single channel of blood flow entering from the common AV valve instead of the two normally placed tricuspid and mitral valve flows. So this is how the AVSD is going to be seen. Next, we come to the abnormalities of the seen in the 3VT view. Again, it's a pattern recognition only, where different patterns of the 3VT gives us a lot of diagnostic clues at a glance. You can see the first one is the normal and others are the abnormal ones, and which different type of disease is presented over here. Like in this case, where we can see that the transverse aortic arch is located to the right of the trachea and the spine, and it's forming the U-shaped vascular ring around the trachea. A right aortic arch can be of three types, like right aortic arch with right ductus, right aortic arch with left ductus, and the double aortic arch. So this is the right aortic arch with left ductus because it's forming the U behind the trachea. There is a right aortic arch with normally placed left ductus. The next case we are seeing is the V2 right variation of the right atrial arch, right aortic arch, which is the, you can see the right aortic arch is also is along with the right ductal. So the total V is to the right of the spine. So this is we call the V2 right. And this right aortic arch can be associated with complex cardiac malformations or maybe a isolated finding also. Now to look for the ARSA, that is the aberrant right subclavian artery. In the 3V2, we use color Doppler. Can be demonstrated in the 3VT view by reducing the velocity of the flow in order to demonstrate the small subclavian artery. The ability to image the ARSA is significantly enhanced when we use the transvaginal ultrasound probe. ARSA has been associated with trisomy 21 and other aneuploidies. Here you can see the normal 4-chamber along with a small perifemoral VSD, but there is a switched connection of the great vessels of pulmonary artery arising from the left ventricle and the aorta arising from the right ventricle, and both great arteries displays parallel course with the aorta anterior and to the right of the pulmonary artery, demonstrated in an oblique axial view of the fetal chest. So it's a case of transposition of the great arteries, that is the DTJ. The demonstration of a single great vessel in the 3VT, you can see here the single great vessel in the 3VT view, which is also taken in the TUI mode, is a clue, first trimester clue to diagnosis of TGA. This was my last slide, and I thank you sincerely for patient listening. And
thank you, Dr. Shankardev, for such an excellent collection of cases. Now we'll move to the panel discussion. Mr. Vishal, please allow screen share.
It is allowed. Just unshare and share again, sir, because I can see that your screen sharing started.
Yes, I think that take a little bit time. Yes.
Yes.
Yep. Good. Go ahead.
Is it clearly visible?
Yeah, it is visible. It is visible.
Thank you. Thank you. Good evening, my respected colleagues and my dear seniors. Now we will start with the panel discussion. We are going to present the same cases in the panel, and on the first trimester cardiac anomalies. The title of the panel is very evident: 4 boxes and 2 pathways. The 4 boxes are the 4 chambers of the heart, and the 2 pathways are the 2 outflow tracts. We have an eminent panelist group with us. Dr. Sita Ramamurthy Pal, Dr. Sumana are the fetal medicine specialists with us. Dr. Dhritarabhata Das is the pediatric cardiologist. We have Ms. Yashodhara Bhattacharya as the geneticist, and above all, we have our expert, our dear sir, Dr. TLN Praveen, for the expert comments. So basically, cardiac anomalies forms 30% of all congenital anomalies which are detected in the first trimester. And the burden in India is huge. It is 9 per case per 1,000 deliveries and 2.4 lakh cases per year. So it accounts for around 10% of infant mortality rate in India. So you can imagine the burden in our country. But it is a teamwork to diagnose them. The obstetrician has to send the patient at the correct time. The fetal medicine specialist or the radiologist has to diagnose it correctly. Then comes the role of the geneticist to look for the genetic tests. And finally, the role of the cardiologist to counsel the obstetrician as well as the couple. So basically, in the first trimester, we are going to look at 4 levels of fetal thorax examination. Firstly, we look for the upper abdomen, that is, we look for the situs, whether the stomach and the aorta is on the left side and the IVC is on the right side. Then we move up to the 4 chambers. We will look for equality of the atria, the ventricles, the crux, the offset, the moderator band, and we will switch on, and the most important part is switching on the color or the power Doppler to look for equal inflows separate from each other, not very close to each other. And when we move up, the 4th level is the 3VT view or the arch view, where we can make out both the arches are crossing each other or not. And we can also make out whether there is any discrepancy between the size of the arches or not. So these are the standard 4 views which we need to examine in the first trimester. There are additional views also, but by these standard 4 methods, we can diagnose most of the anomalies, as we saw in the presentation. So we move on to the first panelist today, our senior Dr. Sita Ramamurthy Pal. Ma'am, what is the abnormality seen in the following clip which I will play? And please describe the ultrasound findings. This is the grayscale and this is the color clip for you, ma'am.
Thank you. Thank you for the opportunity. Thank you, SFN. So, yeah. So basically, we can see that the 4 chamber is looking grossly abnormal, with the left side of the heart being very small and underdeveloped. So, and there is with the color flow as you've shown. Can you show me the 4 chamber color flow as well? Well, there is looks like there is no flow across the mitral valve.
Yes, ma'am.
And possibly a regurgitant flow across the tricuspid. So this will fall into the category, as we've seen earlier, into the hypoplastic left heart syndrome, where there is basically gross maldevelopment of the left side of the heart with disruption in the systemic circulation. So the 3 vessel view, yeah, you want to say something?
No,
so here we can 3 vessel trachea view. Very typically, there is dilated, actually there is a diminutive aortic arch and a dilated pulmonary artery with a reversal of flow in the aortic arch. So very typical of the findings of hypoplastic left heart in this scenario in the first trimester.
Yes, ma'am.
Yeah. So okay, so basically it is basically a complex, it is a spectrum of abnormalities. It can go on from from aortic atresia, mitral atresia and aortic atresia together, and it is very difficult to differentiate it from critical aortic stenosis. But usually if you see it in the first trimester and of this severity, then the prognosis can be pretty bad at this stage, where it's not going to be compatible later in life.
Thank you, ma'am. Thank you. So basically, we are looking at these 2 classic forms of HLHS. One is where there is aortic atresia, where we see a slit-like left ventricle. We cannot actually see the left ventricle at all. And the second version is where the left ventricle becomes globular and echogenic and poorly contractile, where there is a aortic stenosis. So the second variant is actually not detected in the first trimester much, which we see mostly is the first variant, where there is a slit-like left ventricle. So the most important point is here that when we see a normal 4 chamber of the heart in the first trimester, it does not rule out HLHS completely, because progressive aortic stenosis can always lead to HLHS later on in the gestation. So, ma'am, next question to you again. How to differentiate a possible coarctation from HLHS in the first trimester?
In the first trimester, coarctation is very, very difficult to, pick up. So,
Yes.
you will have a normal 4-chamber heart, and, so usually you will, if you see this sort of an abnormality, you would not think of coarctation in the first place. But definitely in the later on stages, if you want to differentiate, there will be some flow across the mitral valve in coarctation, and there will not be
Yes.
a reversal of flow in the aortic arch, as we've seen.
Yes.
So if there is suspicion, if there is a discrepancy in the ventricular size, we'll obviously have to call her back again at 16 weeks to make sure what sort of abnormality we're looking at. But in coarctation, definitely there will be some amount of flow across the mitral valve, and that will be your clinching sort of.
Yes, ma'am. Forward flow in the aortic arch is the most
flow.
differentiating point from HLHS. Thank you, ma'am. Next question again to you, ma'am. Please describe the abnormality which we are seeing in this clip. This is the grayscale, and this is the
We've seen this
color
clip
clip.
before, right? Yeah. Okay. Yeah. So basically, again, this is a abnormal 4-chamber heart with the right side of the heart being, the reversal of the typical finding, the mirror image of the left
Yes.
maldevelopment. So the right side
Right.
looks very underdeveloped with the 4-chamber color view. If there's any flow across the tricuspid valve.
No, ma'am.
And there is a small VSD here. Yeah.
Yes.
So it could be it's tricuspid atresia with ventricular septal defect.
Yes, ma'am.
Well, again, very difficult, fantastic images, I must say, and very difficult to pick this up. Obviously, there is a high degree of, there is completely tricuspid atresia, then you'll be able to see a hypoplastic right heart, as we've said, and the right atrium and right ventricle will be, can be dilated if the tricuspid valve is insufficient.
Yes. Thank you, ma'am. Thank you. So basically, what we are looking at is a hypoplastic right heart, where two common conditions are there in the first trimester. One is with an intact septum, and another is with the VSD. So intact septum, the pulmonary is atretic, pulmonary artery is atretic, and when we have a VSD, the tricuspid valve is atretic. So TAVSD and PAIVS are both the conditions which will give us to a hypoplastic right heart in the first trimester. Next, we thank you, ma'am. Thank you so much for your comments. And we move on to our next panelist, Dr. Sumana. Dr. Sumana, are you there?
Yes, yes. Thank you. Thank you for the opportunity.
Look at the clip and give your diagnosis. So this is a normal 4-chamber heart which we are playing. This is the abnormal grayscale, and this is the abnormal power Doppler. This is the abnormal color Doppler.
Okay, so after confirming the situs and the axis of the heart, I will look right into the center of the heart and see whether there is a defect or not. And here I can see a defect, and during that is more prominent during diastole. And during systole, I can see that the valves are more linearly inserted rather than the tricuspid valve, which should be more apically placed.
Right.
In the colored Doppler images, I can see that there is one single channel flowing into the atrioventricular valve, and this is later on dividing into two, and
Right.
there is some kind of regurgitation in the middle of the valve.
Perfect.
So this is most probably atrioventricular septal defect.
Yes. Please describe the anomaly for us.
So atrioventricular septal defect is the defect basically in the septum primum of the atrium and the inlet VSD. So what happens here is that so there is linear insertion of the valve, and we are unable to see the normal offset, and
Right.
as a result, and then the color, it confirms our diagnosis, where we can see that there is a single channel flow and there is a regurgitation, and a regurgitation which can be confirmed with the pulse Doppler, and more so if we find a regurgitation in the left side of the heart.
Right. Thank you. Thank you so much. So basically what we are looking at is a balanced complete AVSD. So balanced AVSDs, as we all know, more commonly associated with trisomy 21, and the unbalanced ones are more commonly associated with the heterotaxis. Now in AVSDs, basically we can only diagnose complete AVSDs in the first trimester. Partial AVSDs are very difficult to diagnose in the first trimester. And in complete AVSD, there are some practical tips to diagnose the anomaly in the first trimester, where we generally the atrial length is is smaller than the ventricular length. So in AVSD, we will see a alteration of that thing. The atrioventricular length is altered. So when we see sometimes on grayscale, the crux and the offset is not perfectly visible in the first trimester. But if you see that the atrial chambers are appearing bigger, maybe equal length than the ventricles, we can suspect AVSD. And if the couple continues that AVSD, if it is an isolated one, the regurgitation of the valve has a very important prognostic sign, because if there is a regurgitation in the valve, the fetus might go on to develop hydrops in the second and the third trimester. So this is the one practical point in AVSD just by looking at the atrioventricular length. So Dr. Sumana, the next case for you, please find out the anomaly in this case. Basically, these are the same diagnosis, but two variants of the same case.
Okay, so in the first image, I can see that the alignment of the aortic arch is more towards the center or towards the right side of the trachea. So,
Right.
And the ductus is in the left side, and it is merging with the ductus in the behind the trachea, forming a U configuration or the
Right.
U sign. This is the right aortic arch, which is with the ductus on the left side. In the
Right.
I can see that the ductus is also in the right side of the trachea along with the aortic arch, and they are merging together, and this forms the mirror image of the normal 3-vessel trachea view. So
Right.
both are variants of the right-sided aortic arch.
Right. So thank you. So there are mainly three subgroups of this right aortic arch. That one is with left ductus, and the other one is the right ductus, and the last one is the double aortic arch, which is very difficult to differentiate. Now the diagnosis is done by putting on the color at the 3VT view. So when we see the V to right problems, and then the intracardiac anomalies are much more common, and it has a very common association with TOF, absent pulmonary valve, double outlet right ventricle, and CAT. So basically, this is the normal, where both the arches are meeting together towards the left of the spine. This is the complete mirror image, that is V to right. The total arch is towards the right side. This is the U, where the ductus is on the left. It is forming a vascular ring around the trachea. And this is the lambda sign for the double aortic arch, which is very difficult to differentiate in the first trimester. Thank you, Dr. Sumana. We move on to our next panelist, Dr. Dhritarbrata Das. Sir, please describe the abnormality seen in the this clip. This is the normal. This is a normal, and this is the abnormal clip. Good evening, sir.
Good evening. First of all, thank you very much for your invitation, because I see as a pediatric cardiologist fetuses at a much later stage. So picking up these abnormalities so early in the pregnancy is really amazing. So can you just go back to the initial slide? Yeah. So what we can see here is basically that the outflow tracts are parallel to each other, and the great artery which is coming out of the left ventricle is bifurcating, and it is the pulmonary artery. Another important tips here is that normally the aorta comes out anteriorly and goes, when it goes out of the left ventricle, it goes anteriorly. And if you look here, it is going posteriorly. That is called the posterior dipping. Right. And the aorta is anterior, and the pulmonary artery posterior, clearly bifurcating here. So this is the transposition, and there looks like there is a VSD also, which is not very small.
Right. Thank you, sir. So basically, in TGA, there is a switching of the great vessels, and as you rightly told, sir, the aorta is anterior and to the right. That is why we call this a DTGA, that is D equals to Dexter. The parallel course which we saw in the clip is demonstrated in an oblique axial view of the fetal chest. So it is not a standard view. It is not a standard view. That is why I told that sometimes we need to do some additional views to diagnose outflow tract anomalies in the first trimester. So single vessel on the CT is of yes, sir. Please go on.
Yeah, just to interrupt, but it will probably not be right to mention whether it is a DTGA or TGA. It is better to say that it is a TGA because we have demonstrated that aorta is anterior, pulmonary posterior. Right, left is not always detected even at this stage. So it will be very difficult. So it will probably be wise to say that it is a transposition of great arteries rather than commenting on DTGA, LTG, because there are so many variations. So there is no point going into the details.
Right, sir. So whenever we diagnose TGA, we can see this is the pictorial demonstration that the arteries are not crossing with each other. And the two most common associations when we diagnose TGA in the first trimester, we have to look for whether there is a VSD or not, and whether pulmonary stenosis is present or not. Because pulmonary stenosis will be much more severe and complex in those cases where there is a VSD present in TGA, because the counseling will entirely be different. It is separate. The counseling for cases with VSD and without VSD is completely different. So it is a case of a transposition of great arteries, as you correctly told, sir. We will move on to our next case. Please describe the still images in the following 4 basic cardiac planes and how does it differ from the normal, sir?
Yeah. Yeah. So first of all, in the left upper panel, the cardiac axis is grossly deviated, that we understand. Both the inflows are fine, and there appears a VSD in the lower right panel, which is looks like a malaligned, and the aorta is committed to both the right and left ventricles. And in the last one, in the 3VT view, we can see that the pulmonary artery is smaller than the aorta, and it looks like there is an early joining of both the great arteries, like a Y sign, which is more like a tetralogy of Fallot.
Yes, sir. So basically the tetralogy, thank you, sir. So tetralogy, the 4th parameter, that is right ventricular hypertrophy, is not seen prenatally. And the TOF with pulmonary stenosis is the classic form of TOF, which accounts for around 80% of newborns with TOF. And TOF with pulmonary atresia or absent pulmonary valve syndrome is the severe form. We saw in the images that there is a normal 4-chamber, but except axis deviation is there. And in Y sign at the level of 3VT is a very novel sign to diagnose TOF with pulmonary stenosis in the first trimester itself. But we have to agree that it is a very difficult diagnosis in the first trimester, because seeing the overriding and the dilated aortic root in the first trimester is not always possible. Maybe the 3VT view is much more diagnostic in diagnosing TOFs, where we can assess the caliber of the pulmonary artery is smaller than the aorta. And if it, as you correctly told, sir, if it joins early, then it will form a Y sign at the level of 3VT. And maybe we are looking at a TOF with pulmonary stenosis. Thank you, sir. Now we move to our geneticist in the panel, Miss Yashodhara. Yashodhara, are you there?
Yes, I'm here.
Please, what are the genetic associations for the common cardiac anomalies we see in the first trimester? And what genetic tests you order for these cases? And is there any role of parental testing or not? Please give your opinion.
Okay, thank you so much. And I'd like to thank SFM for this opportunity. So congenital heart diseases is one of the most common congenital things which are seen during the first trimester. And it could, even isolated cardiac anomalies, be associated with an aneuploidy or genetic syndrome. So diagnosis of a cardiac anomaly in the first trimester actually is helpful for pregnancy counseling, and it provides enough time for diagnostic testing. Cardiac anomalies may also be associated with extracardiac malformations as a part of a wider genetic syndrome. So the most important part when it comes to defining which test we want to take, which test is most suitable, is to understand that are there any other extracardiac malformations which our doctors are seeing? Is there any family history which is significant? Is there any obstetric history in the previous pregnancy, something because of which some ultrasound finding or some miscarriage in the pregnancy, which could also give information regarding whether it's an aneuploidy or a chromosomal aberration. So this is very significant for us when we do decide test for cardiac anomalies. The most important, the few which we do see, the HLHS, we can see around 4 to 5% incidences through Turner syndrome and Edwards syndrome and Patau syndrome. And we know that these are aneuploidy. So for an aneuploidy, the test we go in for is QFPCR. It is actually, if we go in for a QFPCR with karyotype, it gives us a bigger picture with bigger deletions if there is any that needs to be seen. Also, HLHS could also be caused due to causing Noonan syndrome, Smith-Lemley, and Holt-Oram, which are single gene disorders. So because there is an overlap of phenotype, it is important to consider that even if your aneuploidy test is coming negative, we need to consider that maybe single gene should be looked into as well. So along with that, coarctation is seen when associated with hydrops is again a chance of Turner syndrome. So this is another information that we get which helps us decide which test should be taken. And with tachycardia and other multiple extracardiac anomalies gives us the idea that it is an aneuploidy. So we can go in for a QFPCR. HRHS, though a rare association, may have, is known to have some few CNVs which may be associated. For such, we may go for microdeletions, and we may go to check microdeletions, and we can use a chromosomal microarray for that. Balanced AVSDs, which are usually seen in the first trimester, is associated with trisomy 21, and 40% are because of AVSDs, the trisomy 21 who do have a CHD. So we can, again, it's an aneuploidy test. You can go in for a QFPCR for that. And unbalanced AVSD is seen due to heterotaxy. Chromosomal reasons for that is less, but it could be single gene disorders. So if this does come in later on, where we get to know that maybe there's a heterotaxy involved, we could consider that test as well.
2 minutes left, Prasanna.
Yeah.
2 minutes.
In case of a tetralogy of Fallow, the most commonly we see it in 22q11.2, which is DiGeorge syndrome. And for that, you can go in for a CMA, or better, the fish is still the gold standard for DiGeorge syndrome. So you could go in for that. TGA, the chromosomal aberrations are rare, but again, microdeletion syndrome in the form of DiGeorge is common. So we should rule that out as well. So after trisomy 21, which has a cardiac association with it, the microdeletion syndrome DiGeorge is again very common. So
Thank you so much. Now we move on to the last question of the panel, and that is to our pediatric cardiologist, Dr. Dhitabodh Das. Sir, which are the defects which have very poor prognosis? Maybe we can suggest termination of pregnancy straight away. And in cases of isolated AVSD or isolated TGA, what the obstetrician needs to know, and how to counsel the parents if they wish to continue these isolated cases, sir. Please give your expert opinion, sir.
Yeah, first of all, if you find that one of the boxes is very small or absent, that is will be a very poor prognosis, because from a pediatric cardiology point of view, we divide the heart problems to main two groups, where is it possible to give the patient a two ventricle future, or it is a single ventricle. If it is a single ventricle physiology, then the outcome is much worse than the two ventricle. Another thing, if it is a left-sided problem, that is usually have a worse outcome. So, suppose if it is a aortic stenosis, aortic atresia, will have a bad prognosis compared to the pulmonary stenosis or pulmonary atresia.
Right.
So whether there are two ventricles is very important. And if one of the outflow tracts, if one of the outflows is absent completely, like a pulmonary atresia or aortic atresia, they have a poorer prognosis, because they can present immediately after birth, and they will have a multiple surgeries required throughout their life. Another thing is that we should not be very much judgmental about whether to terminate or not, but rather the decision should always be to the parents. As a doctor, we should counsel them the pros and cons, that we should tell them more of a negative counseling if we find that it is a single ventricle anatomy where the child will not have a absolutely normal life. But like if you think of the TGA, this is one of the heart problems which has a very good outcome. So if it is detected antenatally and operated in the first few weeks of life, then most of them will have a normal life and will not require a repeat surgery. Compared to an isolated AVSD, if it is a balance, again, the outcome is relatively better. But if it is an unbalanced, that means it is a single ventricle physiology. Right. So if it is a two ventricle balanced AVSD, most of them will have a good life, but there is an association with other chromosomal abnormalities which should be ruled out, and they will often require multiple surgeries because of the AV valve problems in future. And for the follow-up in these isolated cases, I will probably like to emphasize that these abnormalities are evolving and sometimes they can worsen. Most of them will not improve, but they can worsen only. And that's the reason we need to closely follow them up till the baby is delivered.
Okay, thank you. Thanks a lot, sir. So now the expert comment from our expert in the panel. This is the last slide and the concluding slide, Dr. TLN Praveen, sir. Sir, please give your expert comments on first trimester cardiac anomalies.
Wonderful. I mean, there was a wonderful presentation by Sankade, and the panel was excellently taken across by Prasanna Roy. And all the panelists have been very, very explicit and have been giving us a lot of inputs. I mean, there are a few things that I would like to put it across, particularly for people who have started evaluating the first trimester cardiac abnormalities. First and foremost thing that we need to recognize or realize that identifying cardiac abnormalities, particularly in India, because of the burden is very high, it becomes more and more empirical that you should be able to identify these as early as possible so that we'll find time for the parents to take a call, counseling them, planning with the team, like a pediatric cardiologist, pediatric cardiothoracic surgeon, geneticist, and all those things put together. Now, more than anything else, the first and foremost thing is that we need to understand that the low risk cases are the ones which have to be kept in mind. High risk, anyway, we do diagnose them, but then there is an incidence of almost 32% of cardiac abnormalities which can be picked up in low risk groups. That is the reason why we need to make this evaluation of fetal heart in the first trimester as a mandate. In the sense, it is always essential that not only that you try to evaluate, particularly when you get a fetus at about 12 weeks plus, that is around 12 to 13 weeks, it's ideal to do a transvaginal examination to evaluate various structures, not only the heart, but also various structures, because now with this transvaginal approach with high frequency transducers, we do get situations where the certain things which are called as unmodified factors in evaluating structural abnormalities can be got over by using this particular technique. And not only that, the expertise and daily, I mean, the learning curves are little steep in a sense, but then we have to keep going to so that we can pick them up as early as possible. Now, most important thing as a beginner, what we need to evaluate is first and foremost thing, the axis of the heart is the most important thing that you should keep in mind. In first trimester, axis of the heart is the one wonderful clue. It tells you that there is something wrong with the heart. So when you take the first trimester evaluation, as usual, when you try to evaluate the aneuploidy, you definitely look for the nuchal translucency, tricuspid regurgitation, and the ductus venosus. All three features are markers which can suggest that there is an associated with the chromosome abnormality, probably a cardiac abnormality. And the fourth most important thing is the cardiac axis. So these are the things that we have to keep in mind. Next, another important thing is please don't hesitate to use color. I'm not saying spectrum, but then the color has to be used in order to evaluate first trimester heart, because the fetal heart as such is small. You need to magnify it as much as possible without losing the resolution. At the same time, use the color in order to, and as you know, the fetal heart is small, it's dynamic, and it is difficult to access. So these are the factors that we have to keep in mind. As an expert, I think most of the things have been covered by the panelists as well as Dr. Prasanna Roy. So I think there is nothing much to add on. But these are the small tips that I would like to put it across to, particularly for the beginners, and encouraging all of you to start examining these fetuses right from 12 to 13 weeks of gestation to evaluate various structures, not only the fetal heart, but also all other structural abnormalities. Thank you.
Thank you so much, sir. Thank you. I sincerely thank SFM for allowing us to present our cases here. Over to you, Dr. Kanchan Mukherjee, sir. Thank you so much.
Thank you, Prasanna and the team. It couldn't be any more succinct, couldn't be. Now, our next presenter is Dr. Khurshid Alam, who will be sharing a number of CNS cases with his team. Khurshid, over to you, please.
So please to unshare so that I can share, sir.
Prasanna, you need to unshare.
God, where it is. Where should I go?
No, you have, yeah, correct.
This one?
Is my slide seen, sir?
Yes, yes, yes.
Yeah.
Your slides are seen.
Ah.
Go ahead.
Okay. At the onset, I would like to thank SFM and Dr. Ashok Khurana sir and Dr. TLL Praveen sir to give us an opportunity to express ourselves as such a big platform. So without wasting any more time, I will just jump on to my presentation. So the title of the presentation is CNS Case Diary, Mind the Missing Anatomical Link. Why I chose this topic, I will justify in my subsequent slides. What is very important in fetal medicine is teamwork. And we will do exactly that. There are two twin first trimester CNS case discussion, which will be followed by the expert opinion. But I would request all of us to just maintain the time so that we finish all the discussion in time without any prompt. So we begin, as you are all aware of Euro 2020 and Copa America 2021 going on. So I have devised our team in that fashion. So we have a very strong defensive line. And then we have a very exuberant captain, the striker. And I will justify why I'm saying so. So he's a mesmerizing, magical Messi of our team, and he will conclude at the end. But let us begin with first rules of the game. The rules of the game is we will do three important things in the multidisciplinary approach. One is discuss the ultrasound and define the phenotype. Go on with the probable genetic test, minimum basic, which practically we can order. And then go on for the basic management plan for the patient so as to give them a safe roadmap to continue their pregnancy or to terminate their pregnancy. Now, the opening premise is I go on with the belief that all of us are doing competent first trimester scan and we are all aware of our image optimization, the physics and the embryology. Now, this is a checklist which I am giving in our clinic. And I've realized that out of this 12, the 5 sections I will be discussing in this presentation. So it's almost like close to 40 to 50% of the entire first trimester. Now, we have to realize the tangible benefits of doing the nuchal translucency in defining other structural abnormalities. So we have to play with our skill set and the mindset. The skill set is how to optimize the image, how to place your probe and align it with respect to the fetus, irrespective of whatever the position the fetus acquires. Take a good optimized image where all the landmarks, necessary landmarks are seen, which will be discussed in the subsequent slides. And then even though if patient is not in a very conducive position, still we can go with the multimodality approach. We can use a transvaginal probe and still get a lot more details. And with now advanced high-end machines, we can dissect into the posterior fossa like never before. And if the baby is completely upside down, then transvaginal scan comes to our rescue in a much better way and which gives excellent details of the fetal brain. Now, for everything in fetal medicine, there has to be a standardization. And I would like to ask Dr. Pushan Kundu sir, that what is the ISIOC standardization or other body standardization for first trimester brain assessment? How are we going to take it? Dr. Pushan Kundu sir, please. Is Dr. Pushan Kundu sir there?
Yeah, I think he's there. Hello, Dr.
Pushan Kundu sir, you have to unmute.
Yeah, you have to unmute yourself. Yes. Yeah, you can talk.
Yeah. Okay.
Sorry, can you repeat the question, please?
Yeah.
I was just a bit
Yeah.
considering or trying to unmute myself.
The question was, I wanted you to highlight on the ISIOG standardization of fetal brain assessment, like what are the basic sections, minimum basic, which we have to do.
You need to see the fetal calvarium. You need to see the fetal, there is the cranial bones, the midline forks, and you need to see the choroid plexus ventricles. And you'd also head and in the neck, you need to see the normal appearance of the neck, nuchal translucency, using the, as per the standard FMF parameters. These are the basic things that we must see for each and every screening in first trimester.
Yes, sir, exactly that. And in 2020, they have just included 2 more planes, a transthalamic and transcerebellar plane. And this is the latest which has come in June 2021. It's a freely available paper. So one can go through it and just form their own checklist, but we have to keep it minimum basic so that we all can do that, and which is very practical. So again to you, sir, Pushan Kundu, sir, can you just explain the sections, like when we are examining the fetal brain, at least 4 sections we have to take to just cover our checklist. So can you just explain them, sir?
Yeah, you in the axial section, you take a section through the like the standard BPD section, where you see the lateral ventricles filled with the choroid plexus, and then you rotate the transducer to look at the posterior fossa, and also you need to do a good mid-sagittal scan.
Yes. Yeah. So essentially, we are dividing into 4 sections, where in one section we are looking at the choroid plexus and midline forks, as Dr. Pushan Kundu sir has already said, and then go on to the transthalamic view, where we will be seeing the aqueduct of the sylvius and the distance with the occipital bone and the thalamus, and then go on to the 3rd ventricular view, and then the 4th ventricular view with the choroid plexus, and the same thing you can see in the video clip. So directly we'll move with our case. So our first case will be presented by Dr. Tulika. Dr. Tulika, if you can unmute and present this case.
Yes, sir. Good evening, everyone. My patient is Mrs. SD. She is 45 years old, 3rd gravida, with 1 living issue and history of 1 first trimester miscarriage. This was her IVF conception with donor oocyte, and 2 blastocyst transfer was done for her. In the medication history, she was a chronic hypertensive on the pregnancy safe medication, and she was hypothyroid, which was controlled on the medication. She was a dichorionic diamniotic pregnancy. We referred to us for the combined first trimester screening.
Can you go through these images quickly?
Yes, sir. In the combined first trimester screening, the chorionicity and amnionicity was reconfirmed, and it was a DCDA pregnancy. While measuring the nuchal translucency of the fetus B, we noticed that the brainstem of the fetus B was prominent as compared with the fetus A. Also, the intracranial translucency and the intracranial translucency was thinned out. We measured the brainstem is to brainstem occipital bone distance ratio, and it was more than 95th percentile. We also compared the axial planes of the 2 fetuses and noticed that the head circumference of the fetus B was very less as compared to the fetus A, and it was a dried out brain as compared with the fetus A. Some amount of CSF can be seen in the lateral ventricles of the fetus A, but in the fetus B, both the choroid plexuses were completely filling the lateral ventricles of the fetus B. We tried to negotiate the spine of the fetus B through the transabdominal route, as it was a non-presenting fetus, and as it was a non-presenting fetus, so we cannot go through the transvaginal route. But no apparent spinal defect was seen at that level. We recalled the patient after 2 weeks, but the patient failed to come up after 2 weeks for the genetic counseling and reassessment of the intracranial anatomy and the spine.
Yeah.
She turned up after 4 weeks.
Yes, Samiran, can you just explain these video clips? Are you there, Samiran?
Hello. Yes.
Yeah,
sir,
Samiran, please go through. Please go through the video clips.
Yes, sir. I can see in the left clip, I can see there is a defect of her spinal cord, and there is a membrane covered myelomeningocele, And in the right side clip, I can see, yes, there is some, there is typical banana sign, like the cerebellum is abnormal and it looks like banana. And the proper lemon sign I could not see.
Yeah, and there is ventriculomegaly and tectal beaking as well.
Yes. The LV is also dilated.
LV is also dilated. Right.
Okay.
So this was a case of open neural tube defect, right?
Neural tube defect, sir, with Chiari 2 malformation probably.
2 malformation. Okay. Then what are the first trimester signs of the open neural tube defect? Can you enumerate? Yeah.
Yes, sir. There is open neural tube defect, first trimester signs.
Yeah. First trimester signs. Yeah. First trimester in the sagittal plane. These are all the signs in the first trimester. But I would like to ask Pushan Kundu, sir, that is a very crucial image where lines and spaces. So can you just enlighten us with this concept of line and spaces, sir, for everybody to understand?
Basically, you look at this space in the posterior fossa behind the sphenoid bone and in front of the occipital bone, and you see three spaces, three translucent areas. That is the brainstem, the intracerebral translucency, or that is basically the fourth ventricle, and behind it you see the system magna. And the lines are the sphenoid bone is the anterior line, and then you have the border, the posterior border of the brainstem, and the anterior border of the fourth ventricle from that's the roof of the fourth ventricle. And behind the fourth ventricle, you see the choroid plexus of the fourth ventricle, which forms the demarcation between the fourth ventricle or the internuchal translucency and the cisterna magna. The normal IT or internuchal is almost, the three are almost parallel to each other. But when there is an open neural tube defect, you will see sort of the effacing or the flattening out of the or reduction of the internuchal translucency. And in some conditions, you can see it increased, which I think we'll discuss later.
Yes, sir. Yes, sir. Yes, sir. So this is a very important concept for all of us to remember. And there can be two ways which we can do. One is the pattern recognition, that is a subjective approach. Other is the objective approach, where you can do all this. You can look at these nomograms, which has been recently given by Valdo-Sepulveda group in 2019. So either of them. But what I would recommend that pattern recognition is good enough, and then you can interrogate directly the spine to confirm your findings. Now, there is an algorithm for abnormal IT. Once you see the abnormal IT, it can be either obliterated or increased. If it is obliterated, you try to see in other planes also, like axial plane, and still if you are finding it decreased, then you go for direct interrogation of the spine to confirm your diagnosis. And if it is increased, then there are three conditions. It can be just a transient finding, which is a benign process will resolve, or it can be any form of posterior fossa cystic malformation, which we'll be discussing in the next case, or it can be a part of a genetic condition. So we have to order genetic tests also in certain situations, which we will be discussing. Now, there are actual indirect markers also. And I would like to just ask Tulika, just tell me one key point, take home point from this axial marker, that which is the most important thing we should see. Tulika, please.
The most important thing we should see is the distance between the aqueduct of Sylvius and the occipital bone posteriorly. There is always some space between aqueduct of Sylvius and the occipital bone. But whenever there is a leakage of CSF, the aqueduct herniates posteriorly and inferiorly, and the distance between both of them is completely reduced. This is called as crash sign. It is given by Alfred Ushakov et al. In 2019. Also, both the cerebral peduncles, which are apparently divergent, becomes parallel to each other.
Okay, thank you so much. Now, a quick question to Mrs. Sutapa, like what will be the genetic workup counseling tips for this kind of case, like DCDA twin discordant for open neural tube defect? What would you like to, how would you like to counsel the patient, the prospective mother?
You, sir. Thank you, SFM, for giving me this opportunity. So according to that, we can go through, like we have to see for the family history. Now, in this case, it was a donor egg. So we have to ask for whether the source of the donor egg, whether the family members had donated or any outsourced format. So most of the cases, usually open neural tube defect are because of multifactorial events, and we have to also look for it because there is a history that the female was also having chronic hypertension, and if that is not maintained properly, it could affect the multifactorial reasons. And in cases where neural tube defect is the only anomaly, karyotyping is not routinely indicated. But if you see other anomalies as well, then possibilities of syndromes like chromosome anomalies can be revisited. In small cases, it is associated with trisomies like 13, 18, and trisomy 9, and unbalanced translocation or triploidy, which is also known in literature as well. So karyotype will be a good option to look for the aneuploidies. Chromosomal microarray can be an optional for better yield and the quick results. For single gene disorder, if you see other multiple anomalies like encephalocele and polydactyly and other forms of that, then it can also be a syndromic form. But for that, first trimester, I don't think so it will be able to detect, and second trimester screening should be like USG should be done, and to know whether it's forming a syndromic type or not. So in that case, exome-based study can be considered for the affected fetus as well.
Okay, so we counseled the similar line, and the patient opted for selective fetal reduction, and we had done the reduction for this, and the other baby was doing well, and we had followed it up till 31 weeks, but after that it was lost to follow-up. Now we will quickly go on to the case 2. Tulika, can you just go through case 2?
Yes, sir. My patient, Mrs. Day, she was 30 years old, primigravida. This was her IVF conception with the donor oocyte, and 2 blastocyst transfer was done for her. She has no significant medical or drug history. This was a DCDA twin pregnancy sent to us for the combined first trimester screening.
Just help us to interpret these images.
Yes, sir. In the combined first trimester screening, the chorionicity and amnionicity was reconfirmed. The rest of the fetal anatomy was normal, but while in the mid-sagittal section of the fetus B showed that the intracranial translucency appeared to be increased. Also, there was only 2 translucent spaces instead of being 3. And when we calculated brainstem to brainstem occipital bone distance ratio, it came out to be below 5th percentile. The rest of the fetal anatomy was completely normal, and the combined first trimester screening of this patient came out to be low risk for both the fetuses.
Okay, so we had few dilemmas here. Is it some kind of transient finding, or a benign Blake pouch remnant, or any kind of serious cystic malformation like Dandy-Walker malformation? How to follow up these cases, and how should we base the genetic issues on this? Now, as I remember, Dr. TLN Praveen sir always says, whenever you are examining posterior fossa, it's incomplete without evaluation of aqueduct of Sylvius and the brainstem. Henceforth, as you can see in this embryological specimen, the same thing can be correlated here in the 3D image, where you can see the isthmus, the aqueduct of Sylvius, and then the fourth ventricle, the choroid plexus, the fourth ventricle, vermis, all the anatomy is very well delineated. So I would also say that one should be cautious in using terms like Dandy-Walker malformations or something like that in the first trimester, because many of the things they resolve are their benign findings. So it's always a good practice to follow up. And if you are seeing dilated fourth ventricle plus prominent aqueduct of Sylvius, it is most likely to be Blake pouch cyst or Blake pouch remnant. And if it is effaced aqueduct of Sylvius, it goes more in favor of Dandy-Walker malformation. Henceforth, always try to evaluate aqueduct of Sylvius when you are getting dilated fourth ventricle. Now, to Dr. Pushan Kundu sir, when would you like to see her back? We have done a first trimester, we have raised a red flag. Now, when do you want us to call this patient back, sir?
I wouldn't wait till the normal anatomy scan. We'll probably see her back in 3-4 weeks, around 15-16 weeks. Then we should be able to evaluate the posterior fossa much more, much clearly, and we can appreciate the different structures better at that stage.
Yeah. So exactly, we did the same thing. We called the patient at 16 weeks, and we found there was ventriculomegaly with dangling choroids and apparently open fourth ventricle, which was communicating to this posterior fossa cystic lesion. So we gave query posterior fossa cystic malformation, because we all understand at 16 weeks we cannot classify, because we cannot fast track the embryology, because vermis starts forming and then it rotates clockwise to close the fastigium or the fourth ventricle, which happens only by 18 to 19 weeks. So if we have to classify based on the Vermeer pathology, we have to wait till 18 to 19 weeks. And this we explained to the couple that it could be a benign findings also. So we don't want to overcall, and let us see you back between 19 to 20 weeks. So the patient came between 19 to 20 weeks. Samiran, can you quickly wrap up this image and say what is the clinching points here?
There is a cystic deformity in the posterior fossa, and we can see in the sagittal section, we can see the BV angle, which is less than 65 degree, and so we can say that this it will be fall in Dandy-Walker complex variant. Okay, in Dandy-Walker complex, there are three type of deformity. You can see there is Dandy-Walker malformation classic, and one is Dandy-Walker variant, and another is Megacystana magna.
Yeah, thank you so much. Thank you so much, Samiran. So the most important thing is elevation of the tentorium, the hypoplastic vermis, which is rotated upwards, and then the angle. So once we have seen all this, it goes more in favor of Dandy-Walker malformations. And this is the report which we generated. And this was our recommendation, non-directive counseling, where we discussed in length about the pros and cons of continuation of the pregnancy, and also genetic counseling and referral to the pediatric neurologist to have a better understanding. And we ordered karyotype or chromosomal microarray to establish chromosomal normalcy. And if they wish to continue, then to have a fetal antenatal MRI between 28 to 30 weeks, which will give more information potentially. Now, quick question to Sutapa. How do you counsel these cases of dilated posterior fossa cyst or prominent fourth ventricle in the first trimester?
So in cases where you see only Blake's spouts or cystina magna or Vermeer's hyperplasia, so in these cases, the chromosomal anomalies are not usually seen, but a very low chromosomal anomalies are noted. Wherein Dandy-Walker malformation, the chromosomal abnormalities are noted as about 16.3%. So in these cases, if Dandy-Walker malformation is apparently isolated, so ultrasound in an ultrasound finding, the high risk of chances that it could be a chromosomal associated structural anomalies. And for isolated MCM or Blake's pouch, it will be low risk for aneuploidy, but we should be ruling out the common aneuploidies as well. So offering a karyotype or a microarray specifically for Dandy-Walker malformation can be a better option too, because Dandy-Walker malformation, also known in microdeletion syndrome like 3q microdeletions, 6p subtelomeric deletions, or 20q13 microdeletions. So that will be an option for them. And if the results came something we find out, we have to counsel them accordingly what is the finding as well.
Yeah, thank you so much, Sutapa. Now, final question to what will be the probable management options for this posterior fossa cyst in first trimester? To Pushan sir. What are the options?
I mean, are we talking about this case with twins or like?
Yeah, this case with twins, sir. This case.
I mean,
with twins,
again,
sir.
like the first case, selective
Yes,
fetal termination is probably the most sensible and you know, more what the patient party will decide to go for.
Yes, sir. Yes, sir. And exactly the patient party, they give the concern for the selective fetal reduction, though understanding the increased miscarriage risk, because we are doing this at 20 weeks, 2 days, and we counsel them that more than 10% miscarriage risk will be there. And they accepted that miscarriage risk, and we had done the reduction. And upon completion of reduction, we have taken the follow-up. Can you just highlight this outcome, Tulika?
Yes, sir. The patient has elective anesthesia at 38 weeks of gestation. Healthy female baby was born. Her birth weight was slightly lower, 2.1 kg, but till this date, the baby is alive, healthy, and immunized.
So I would like to conclude that fetal first trimester evaluation of fetal CNS is very tricky because, as you know, CNS is something which keeps evolving over the period of gestation, and we need a standardized anatomical approach because that can be a single greatest factor influencing the detection rate. And also we need to understand certain hints, and so those hints are understanding the subjectively the lines and spaces, the pattern of the fourth ventricle, the choroid plexus of the fourth ventricle, which may give clue to a lot of diagnosis. And now there is a paradigm shift from nearly always detectable abnormality to potentially detectable CNS abnormalities with increasing knowledge of the CNS and high-end machines. So we are progressing towards the potentially detectable abnormalities, and the cases which I discussed, they fall in the potentially detectable abnormality. And also I would like to encourage all to attend SFM meetings to update, and don't hesitate to call for help. So you can always join us in an ever-growing family. Thank you so much for your patient hearing. I hope I am on time. And now over to expert for his opinion on the cases.
Okay, thank you.
Thank you,
Change
sir.
the
Thank
slide,
you,
please.
Yeah.
Okay. Now, thank you very much, Khurshid. You have done a wonderful job, wonderful case selections of twins, one abnormality, and the panelists have done a wonderful job. Now, what is important for us to realize is that whenever there is a twin pregnancy, especially discordancy is there, I mean, dichorionic diamniotic pregnancy, we have to be absolutely sure that the other fetus is okay. So yes, we concentrate on the abnormal fetus, we deliberate a lot on the abnormal fetus, but we have to understand that ultimately, probably we are going to do a selective feticide, and then we have to be absolutely sure of the normality of the other fetus. That is one thing that we wanted to emphasize. Now, also when we do a CNS evaluation, as we all know, as per the guidelines, there are certain things which should not be missed, like in neural tube defect, as you suggested, anencephaly, exencephaly, or acrania, or encephalocele. These should not be missed at all. Anencephaly as well. So, but there are situations where, for example, the one which you discussed, the first case, reduced intracranial translucency, or the crash sign, as it is called, the reduced BSOB diameter. These are all indirect signs of ONTD. And one should not actually base a diagnosis on these indirect signs at all. So whenever we see these things, whenever there is suggestion there may be some abnormality, then we should always resort to a TVS straight away in the same sitting after taking proper consent, and try to actually visualize the defect. If we can actually directly visualize the defect at the end of the spine, then only we can clinch a diagnosis itself in the first trimester, and we don't need to bring the patient back at 16 weeks or so. So it's only when, that is my opinion. So if there is still a doubt that yes, we are seeing all the indirect signs, but still we are not able to localize the spinal defect or a defect anywhere in the brain somewhere, then of course we have to bring the patient back. So that is what I wanted to say. So they should be differentiating between the one which we can clinch the diagnosis and the where we should not be clinching a diagnosis. Now, as for the views you said, majority of the abnormalities are excluded by doing the transventricular view and the mid-sagittal view. And recently, yes, the thalamus peduncular view or the thalamic view, as you said, or the transventricular, fourth ventricular view, or the transcerebellar view, showing the open fourth ventricle. These are very helpful. And really, if you are doing these sort of sections, then ideally one should go for the transvaginal, I think. So that is very important. Otherwise, you're doing transabdominal, you are doing these extended views, and still you may be doubtful whether it is there or not. So that is something which we should be careful. And if there is any problem, we should bring the patient back. Now, as far the diagnosis the first trimester is concerned, especially about these indirect signs, for example, IT, the one which you discussed in the first case, as well as the second case, the intracranial translucency, there is a lot of false positivity as well, we should not forget. And that causes anxiety in the mother, and maybe unnecessary MTPs also. So it is very, very important that we counsel the patient, and especially what happens, the scanning time is extended. Whenever there is a problem, we extend the scanning time maybe calling the patient back again after 5 minutes, 10 minutes, or we may call in somebody else and discuss these things in front of the patient. So even if we don't write, they get to understand there is something wrong, and then they hop around here and there. So these are some things which are very important, that we should not unduly cause anxiety. So yes, false positivity is something which we wanted to mention. Now, another thing is important, that whatever, yes, you do a selective reduction, or in a singleton pregnancy, we terminate the pregnancy, but it's also important, especially singleton pregnancy, we should be counseling the patient that next time that she should have folic acid. And these days, we are not giving only folic acid. The recommendation is to give methyl tetrahydrofolic acid, because these are the patients who have a history of open neural tube defect. They often have MTHFR polymorphism, as you know, because tetrahydrofolic acid is the one which is actually biologically effective. We all knew that giving folic acid supplementation could reduce neural tube defect by around 60% or 66%. And we didn't know that why in the rest of the cases, it does not prevent. Yeah. Now, at least we know that in around 20% of cases, they can be having this defect in this enzyme, which converts folic acid into tetrahydrofolate. So if we have to give supplementation, it is always better to give a methyl tetrahydrofolate rather than giving folic acid starting 500 micrograms 3 months before the pregnancy. So this is something, this opportunity should not be missed. That is very important. Whether we do genetic counseling or not, neural tube defect is debatable. But yes, it can be syndromic associations. I'm sure there can be syndromic associations with open neural tube defect. But more importantly, we should be absolutely convincing the patient they should be having open neural tube defect. Now, coming to the second case, it is a case of increased nuchal translucence. It's exactly the opposite. So there's a dilated fourth ventricle, any cyst is there, as you said rightly, Blake-Spouse cyst or Berman agenesis or the Newark malformation, and it is extremely difficult to actually come to a diagnosis in the first trimester. In the first case, in open neural defect, you might be able to come to a diagnosis if you directly visualize. But in the second case, it is almost very difficult to come to a proper diagnosis. And in cases, as we said, whether we bring the patient back at 15, 16 weeks, or in majority of cases, we have seen, even if we bring them back at 15, 16 weeks, we are not able to exactly differentiate between a Blake-Spouse cyst, which can be carried on, a Dandy-Walker malformation, which needs to be terminated. So in these cases, I would suggest, what I do in my practice is bring them back at 18 weeks rather than 15 weeks. So there is no point in bringing them 15 weeks and then again bringing them back at anomaly scan. So these are the, but it has to be individualized. If it's a barn door case of Dandy-Walker malformation, there's no point in waiting till 18 weeks. So I think having said that, all the panelists have done exceedingly well. And I must say, Krushit, you have done a brilliant job. The sections and in your extended machines and the planes and all were very perfect. Thank you. It was a great learning exercise for me as well. Thank you. Over to Kanchan.
Thank you so much, the panelists, Dr. Kushal Ghosh, the expert, and Krushit, for your excellent demonstration of cases and a very systematic approach as to how to deal with these cases in the first trimester. So thank you once again, and thank you all panelists. I think before we start off for the next, do we have a trade video now? So we move on to our next case discussion of spectrum of another organ which anomalies can be detected in the first trimester, which is a spectrum of abdominal wall defects. And to present that, may I please invite Dr. Pradeep Goswami, who is another fetal medicine consultant and director of Fetomat Institute, Kolkata. Pradeep, all yours. Unmute yourself.
কটা নাম্বার? হ্যাঁ, ওর কাছে দুটো নাম্বার আছে তো, 700 বলে আরেকটা নাম্বার আছে।
Yes, am I audible?
Yes.
Yeah, okay. So, thank you very much. Yeah. Is the screen visible?
Yes, sir.
Okay. So, carrying on with the presentation, After such prolific, presentation from Prasanna and Khurshid, we are going to eat the dessert. So the spectrum of anterior-abdominal wall defects and algorithmic approach. We have with me Dr. Omitra Shudan Rai Chaudhuri. We are going to present 3 cases. And then we have a esteemed panel, Kanchan, my friend, Dr. Kanchan Mukherjee, Debashmita Mondol, Dr. Debashmita Mondol, Dr. Dipanjana Datta, and also Omitra will be there as well. And obviously, as an expert, we have none other than Dr. Ashok Khurana. So to start with, I'll just play a quick video. It's a very short video on embryonic folding, how it works. So after knowing this basic thing, so as far as the causes and associations of abdominal wall defects are concerned, we may have isolated defects, we may have abdominal defect as a part of polymalformative syndromes. It may be associated with chromosomal aberrations, or it can be part of genetic syndromes. Then these are the types of ventral defects. We should never forget about the physiologic midgut herniations. Omphalocele and gastroschisis are the commoner ones. And then we have body struck anomalies, bladder extrophy, cloacal extrophy, and also OEIS complex. Then pentalogy of Cantrell with or without ectopia cordis. And also there will be associations with amniotic band syndrome and prune belly syndrome. We are not giving these last two as a part of discussion today. So now I will ask, I will stop the screen share and I will ask Dr. Omitra Shudan Rai Chaudhuri to present three cases, and then I will take over again. Thank you. Omitra, you please share the screen.
my screen visible?
Yeah, it is.
So, good evening, everyone. Thanks for giving us the opportunity to present our cases in this platform. So, this session will talk about the spectrum of first trimester abdominal wall defect and algorithmic.
Just present the cases, Omitra. Just present the cases.
So, we'll be going through 3 cases. The first case.
What happened?
Maybe you can click anywhere on the screen. It might work instead of the next button. Just click anywhere on the screen. That's right.
Thank you, sir. 34-year-old lady, G2P1, gestational age of 13 weeks and 2 days, came for her first trimester screening. She had a regular menstrual history and history of hypothyroidism on supplementation. No other significant history of chronic illness or prolonged use of medication. The CRL was corresponding to 11 weeks and 5 days. So during scanning in the longitudinal view, we came across the huge subcutaneous edema and an anterior abdominal wall defect. The NT is increased. The video clip showing the anterior abdominal wall defect with herniation of gut and this hypoechoic liver and echo-reflective membrane here means it is bounded by a covering membrane. The stomach and heart is on the same side, apex of the heart towards the left, as well ensuring the normal situs. The cord is inserted directly into the defect. The fetal brain showing an intact calvarium with the absence of midline falx and monoventricle. And there is also a cystic posterior fossa lesion. The profile view is showing an intact palate in one side and a gap in the palate on the other side. The coronal views are showing 2 orbits and maxillary triangle in which the base of the triangle is deficient. And we can see the normal mandibular gap here. The heart shows leftward axis deviation along with a broader right inflow and a narrower left inflow. And in arch view, where there should be a ductal arch and aortic arch, we are seeing a single outlet which is dilated. The profile view shows a globular structure, globular defect, premaxillary area. For comparison, here is the normal fetus. And upper and lower limb post-axial polydactyly. So the observations here in this case is the subcutaneous edema with increased NT, allobar holoprosencephaly with cystic posterior fossa lesion, a probable median cleft lip and cleft palate, a cardiac axis deviation towards right with narrow left inflow and single outflow tract, anterior abdominal wall defect with herniation of bowel and the liver covered with a limiting membrane, post-axial polydactyly, and since the lady had a normal menstrual cycle and we are getting a significant growth lag in our CRL, got 11 weeks, 5 days. So it may be a wrong date or an early onset of growth restriction.
Mitro, we shall discuss this case now because we may not get time for the other cases. So I'll just discuss this case. Stop your screen sharing and then we come to the second case, you share again. So stop your screen sharing now. Stop your screen sharing. Yeah. So basically, we carry on with this first case. Okay, so as we have rightly seen, these are the findings of the first case, So first question to Dr. Kanchan Mukherjee, what would be the probable diagnosis and how will you counsel this patient, Kanchan?
See, as nicely demonstrated by Amitro, we have a number of problems. We have craniofacial abnormalities, we have cardiac abnormalities, we have abdominal wall defect, we have polydactyly. So a type of syndrome is very likely. And first thing that comes in mind is trisomy 13, but I'm never sure between trisomy 13 and 18 until and unless I have done further genetic investigation. In terms of anterior abdominal wall defect, it is omphalocele. Thank you.
Okay. So basically what Kanchan is saying, because of the parameters involved in here, trisomy 13 is a likely diagnosis. But as we face all in cases like this, we lose the follow-up and patients do not follow the advice that we give. So typical diagnosis is often difficult to pinpoint it. Then coming to Devashmita. How comfortable, as we have seen, this case might be a small for date or it might be early gestation. How comfortable you will be in confirming an anterior abdominal wall defect below 12 weeks and why?
First of all, thanks to SFM for giving me opportunity to be in the podium, and thanks to Dr. Pradeep Goswami for giving this kind of questions. It's a really very nice question that actually I would like to first tell. I will really, what you have shown the slides, those are really important slides you have went through basically. That is my answer actually. I need to count down on the embryological consequences basically. Embryonic maturation occurs at around 4th weeks of gestation, and that divides into midgut, hindgut and foregut. Here we are concerned about the midgut only, because midgut here there is the total intra-abdominal walls and everything that is concerned to the midgut. So what happens in the embryological period, these intestines basically they push up to the umbilical cord base and they rotate to the 90 degree as well as 180 degree again come back to the abdominal cavity. In this way the rotation happens. If there is an incomplete rotation, then there is actually hernia happens, the pathology happens, the physiology alters and the pathology happens. So naturally we need to know what is the difference between the physiological hernia and what is the between the pathological hernia. Usually we need to actually calculate a CRL length of 44 millimeter to ascertain the physiological hernia. That is the time bound. The gestational age is around 11 weeks, 5 days at around 44 millimeter. It is very important. And next, the size of the sac basically below the umbilical cord. It has to be within 7 to 8 millimeter. American Society has contributed as 11 millimeter. Somebody has within the 10 millimeter, European Society. But all are within the 10 millimeter. So after that, it is the umbilical hernia. So that's why this physiological hernia is a very important to ascertain the diagnosis, to differentiate the pathology basically that you have explained.
So basically what you are saying that we should not rush in. Physiological hernia is rarely seen after 12 weeks and usually it does not contain an organ like liver. So next question to Dipanjana, can you tell us very briefly what are the likely chromosomal association as Kanchan has pointed, and what prenatal and or product of conception test that you may offer in this case? Dipanjana?
Sir, thank you SFN for this opportunity, and thank you everybody for having me here. So as Dr. Kanchan Mukherjee sir has rightly pointed out that in these cases, the most common would come with trisomy 18, 13, going down to trisomy 21, then X, Klinefelter syndrome, Turner syndrome. But at the same time, what we also need to understand that there is also 1% chance that there are inversions. These are inversions in chromosome 2. These are inversions in chromosome 3, in chromosome 16. So if you're just doing probably a FISH or a QF-PCR, there is a chance that you might be missing these inversions. The other thing is that when you are looking at just the first trimester, there might be associated other other flags which might not be visible properly or might not be very evident at that time, and there can be association of other organs as well which you might be missing. So in some cases we might also need to go for a chromosomal micro microarray, depending on if we are seeing anything else, like if there is any other abnormality, like in the head or in the limbs or anywhere else, if we are looking at any in the heart, if there is any other abnormality.
So basically,
there are
Dipanjana, you are
duplications.
saying, Dipanjana, you are saying in cases like this, you shall opt for definitely karyotype and with microarray in an ideal scenario.
In an
That is
ideal
what
scenario.
scenario.
Absolutely, sir. Yes, sir.
So, Amitra, you now go on to your second case, please. I'm stopping the screen sharing. Amitra.
Yes.
Go on to the second case quickly.
Yes. 25 years lady, primary gravida, came for her routine first trimester screening. She is hypothyroid and supplementation. There is no other significant history or history of drug intake. CRL was 11 weeks and 2 days. So on ultrasound, there is a large...
not seen.
Sorry? Yeah, it's fine. Go ahead. Go ahead. It's visible. Go ahead, Amitra, quick.
So there is a large anterior abdominal wall defect with herniation of bowel and liver also without a limiting membrane. The clip is showing that the defect is large enough and it comes up to the lower part of the thorax, and the heart is shown at the base of the defect, and some part of the heart is also herniating into the defect. Cord is inserted below the defect, not onto the defect, but it is inserted below the defect.
Yeah. Yeah. Go on to the
The
findings.
profile view is showing absent nasal bone, and here is the prominent looking bladder with a single umbilical artery. So our observations in this case are anossified nasal bone, supraumbilical ventral wall defect with herniation of bowel and liver without any visible limiting membrane. The defect also involves the lower part of the thorax. Part of heart is herniated into the defect. Umbilical cord is not inserted into the defect. Prominent fetal bladder and single umbilical artery.
Thank you, Amitra. Stop screen sharing. I will share my screen now. Okay. So my first question in this case will be to just yeah. So first question in this case to Dr. Debasmita. What would be the probable diagnosis and how will you counsel this patient? Very briefly, please.
Yes, sir. Actually, absolutely a very rarest of the rare case. I must congratulate to you present in this seminar, and everybody can go through this case. Actually, we are lucky enough to go through this case. It is almost incidences 1 is to 65,000 or many kinds of incidents, very rare.
What's the diagnosis, Debasmita? Tell the diagnosis, please.
Yes, sir. Actually, my probable diagnosis is pentalogy of Cantrell, actually.
Yeah, and also probably ectopia cordis, because we can see the apex outside the heart. So what are the things you will say in pentalogy of Cantrell, please?
Yes, sir. Pentalogy of Cantrell is a basically syndromic approach of many kinds of anatomical defects. It may be due to diaphragmatic defect, it may be due to the connection of the pericardium with the peritoneum, as well as omphalocele and other things. So many things will be there, but ectopia cordis is a basically misnomer that we use in the pentalogy of Cantrell. It is the basically apex position of the heart that shows in the pentalogy of Cantrell.
That is exactly which is visible in this case.
Exactly, that is in the thing.
Dr. Khurana, would you like to add anything else in this, what Dipanjana had said so far, Debasmita had said so far?
Yes, just one sentence here, and that is that you have to try and look at the umbilical cord very, very carefully, because if the umbilical cord is not seen and the fetus is close to the uterine wall or to the placenta, then you know that you're looking at a body stock anomaly and not a pentalogy. And very often in pentalogy, you don't find such a large anterior abdominal wall defect, but here apparently it is a very large defect. And so it'll be useful to trace the cord more carefully, which has been traced in this case. So this is definitely pentalogy.
Okay, thank you. Dipanjana, so does all phenotypes that may be associated with a chromosomal aberrations or a genetic mutation will always be seen one affected single fetus? What is your view?
I would here stress that sometimes this is a pentalogy of Cantrell, but there can be other defects which are seen where we don't get a full expression of all the features which we are looking at. Because there can be two things. Number one, if we are looking at a chromosomal deletion or a duplication, it can be partial. And if it is partial, the region of chromosome it is actually involving, which is will actually direct the amount of the like translate into what phenotypes we are looking at. In case of pentalogy of Cantrell, again, this is an X-linked dominant disorder. And when we are looking at such dominant disorders, there can also be a difference in the expression, which we might not find all the symptoms at one time. So maybe a follow-up, maybe like we need to follow up to look at these signs when we are getting one or two signs.
This is a very important point, Dipanjana, you have raised, that whatever is written on the books, you may not see. So in first trimester in particular, you will probably give a probable diagnosis. I'm stopping my screen sharing here now. So Omitra, yeah, tell me quickly.
Actually, pentalogy of Cantrell can be associated with midline defects as well, like cleft lip, cleft palate, and all that.
Yeah, that's absolutely true.
Yes, sir. So then, how the genetic test should be we should go through.
Okay, so basically, again, if you, they have to be customized. There are some slides towards the end. We are going to talk about that. So, Omitra, please share your screen. Case 3.
Case 3. So, 25 years old lady, primary gravida, came for a second opinion of possible myelomeningocele. There was no history of any chronic illness or drug intake. Placenta was anterior and fetus appeared close to the placenta and in a fixed position without much of movement during the whole period of scanning. The images shows a large anterior wall defect which is covered with a membrane. There is a gross curvature abnormality of the spine at the level of lumbosacral region, and there is a short length of cord which could be identified. The profile of the fetus was apparently normal with normal premaxillary triangle and mandibular gap. The heart appeared normal, fourth chamber, and there is a bladder visible clearly here. So our observations in this case are short segment of umbilical cord, anterior abdominal wall defect with herniation of liver and bowel covered with a limiting membrane, and gross curvature abnormality, kyphoscoliosis in relation to lumbosacral spine.
Brilliant. Now I will share my screen. So please give me the screen. Thank you. Okay. So case 3. So first point to Omitra, what would be your probable diagnosis and why?
So the possible diagnosis for me is the body struck abnormality, because the fetus was close to the placenta. And there is a short segment of umbilical cord, a large anterior abdominal defect, and a gross spinal deformity, with a differential diagnosis of an amniotic band syndrome.
Okay, fair enough. So Kanchan, it's a very important question. How comfortable you will be in diagnosis and communication of polyamalformative syndromes in first trimester? We have seen quite a few cardiac, cranial, and now we are discussing the abdominal wall. How comfortable you will be in communicating to a patient in first trimester that you have a polymalformative problem?
I mean, before answering this question directly, I just want to leave one question for Dr. Khurana to address later, whether I should call this a limb body wall complex or body stock abnormality given the spinal deformities. Now, to answer your question, I think we have to be very careful. Now the machines are very advanced. We can see a lot in the first trimester. Our knowledge level has also advanced. So we have a tendency to diagnose things early, and we are successful in most of the cases. But then there should be a word of caution, as Dr. Khurshid Alam mentioned during his presentation, that you should be very, very careful about labeling someone as dandy worker in the first trimester. Likewise, in this case, we should again really have our restraint, and wait maybe a little later. So all polymorphic, I mean, there should be high index of suspicion as the theme of this evening's program goes, but you don't have to make a final diagnosis in the first trimester. That's what I want to say.
That is why it's a hens night on behalf of SFM. So Dipanjana, your question is, what are the limitations in diagnosis of genetic syndromes in first trimester?
Number one, I would suggest that, as I have been saying, that all the phenotypes might not be visible. Also, certain genetic disorders, like which is associated with such abdominal wall defects, might be more clearer in the later part of the trimester, like BWS syndrome or Kagami-Ogata syndrome. And we also need to look at the maternal alpha-fetoproteins, which are actually spiking after 13 weeks. So in these cases, rather than just naming them or just saying anything, it is wise to probably call the patient again, counsel them accordingly. And there can be other genetic syndromes normally that can be related with abdominal wall defects, which is the hedgehog pathway. There can be any mutations in the hedgehog pathway which can lead to such presentations. And we might be missing the test, and we might not be picking up the test correctly. Like if it is a BWS syndrome, any type of chromosomal aneuploidy or exome sequencing will not pick it up. We need a specific MLPA, methylation specific MLPA, which needs to be done. So the patient.
So that is why, Dipanjana, it is very, very important. That is why it is very, very important. We closely communicate with our geneticist colleague, the clinical geneticists, in formulating the test. And one quick answer from you. Between amniocentesis and CVS, we are diagnosing these problems in the first trimester. Which test, just name the thing, which test you will prefer? Is it the amniocentesis or a CVS from the genetic point of view as a preferred test?
So as a preferred test, I would go for amnio, but from the lab perspective, maybe a CVS is better. So.
Dr. Khurana, the point that has been raised by Dr. Kanchan, what is your view in this case?
Yes, so we have very clear definitions because of the implications in the future. And the body stock anomaly is confined entirely to the body stock, which means you have an absent umbilical cord, that most of the abdominal viscera lies in the extraembryonic coelom, and you can really not trace anything that you can call a cord, and the limbs are generally normal. Whereas in the limb body wall complex, the limbs and the spine become extremely abnormal. Of course, spinal anomalies can be present in both. It's rarely possible in these situations to ever be able to see the cord itself. So that is to answer Kanchan's question.
Okay, so I'll just wrap up the three cases. Location of the umbilical cord is very, very important, as Dr. Khurana was saying. So if the defect is to the right of the umbilical cord insertion, you think of gastroschisis, and if it is onto the apex of the defect, you think of omphalocele. And gastroschisis is the evisceration of bowel floating freely in the amniotic fluid, while the omphalocele is a midline sac containing bowel and/or liver. So continue with the location. If the defect is above the umbilical cord insertion, you look for other abnormalities. And if definite 5 of them are present, you think of POC, and at least 3 to 4 out of these 5 defects are present, you should call it a probable POC. And then if the insertion is paramedian with a short cord or overall absent cord, you look for craniofacial abnormalities and limb defects. If it is a dominant abdominal wall defect, probably it's a BSA, and which is usually associated with the exencephaly. And if it is a dominant limb defect, you think of limb body wall, which can be 2 types, the placento-abdominal adhesive type or the placento-cranial adhesive type.
Pradeep, 1 minute left.
Yeah. So if the defect is below the umbilical cord insertion, you think of OEIS complex with a cloacal exstrophy, and the bladder exstrophy are the probable diagnosis. In bladder exstrophy, the bladder is not visible, then anorectal malformations and genital tract defects are present. And in the cloacal exstrophy, there is no gut herniation. In OEIS complex, there is omphalocele, exstrophy, imperforate anus, and the spinal defect. Now, the final question to the expert, Dr. Khurana. So we know like all these complex defects do carry bad prognosis. We need to investigate them to reduce the chances of what are the chances of recurrence in future. So for the correctable abnormalities, what is your view out? How will you counsel the patient about the prognostic factors?
Thank you. And that really refers to almost winding up what is for the entire evening, and that is that the phenotype needs to be analyzed in detail to be able to give a prognosis of this pregnancy, as well as to guide the genotype, which will give us the prognosis of future pregnancies. We also realize that genetics is advancing at a rapid pace, as you already heard, and there has to be a continuing dialogue between the ultrasound phenotype obtainer and the person who does the genetics. Now, in this situation, the first thing that we have to realize is whether a malformation is only in one system or is it associated with other abnormalities. And that's the first thing. The more the associated abnormalities and the greater the chances of a syndrome, and therefore you have a poor prognosis. In fact, for an omphalocele, sometimes it is the associated abnormalities that cause the abnormalities, that cause the poor outcome. In an omphalocele, we know that 75% of them are associated with genetic abnormalities, and therefore it becomes very important to actually, in addition to the appearance of the sac, make sure that we have an adequate genetic workup. Within the omphalocele itself, it is necessary to find out whether it's a giant omphalocele or it is not, and the usual cutoff for the pediatric surgeons is 5 centimeters. Also, as you have shown in this beautiful slide, the presence of liver within the sac. And that becomes a poor prognostic factor. And the prognosis is never complete without genetic evaluation. In a gastroschisis, which we don't have a case today for paucity of time, we do understand that the genetic associations are very few, but the prognosis depends on how early it was discovered. First trimester diagnosis of gastroschisis very often has a very poor outcome, whereas, and in fact, it can be missed in the first trimester. And if you have herniation later, then the prognosis is a little better because the bowel does not become necrotic. As far as all the others are concerned, it's very important to make sure that we actually even look at genitalia, because in a lot of the extrophies, especially cloacal extrophy and bladder extrophy, we have bifid external genitalia and ambiguous genitalia. So therein, we have to realize that we're working within the ambit of the PCP and DT, and we have to use our words carefully. The essential thing here really is making sure that you spend more time on the phenotype. If we don't do that, then we are stuck. The other thing to be explained to the patient is that you might want to have this baby, but in the extrophies in particular, it's a series of abnormalities that later on will need physical correction with multiple surgeries.
So what is the summary, sir, of this night? What is the summary for all the discussions? What the participants are going to take home for all first trimester abnormalities?
It's a privilege to be able to say that we must do the 11 to 14 week scan. There's no question. The 11 to 14 week scan is no longer just a Down syndrome detection scan. It is an anatomy scan, and it is probably a huge anomaly scan with far more wide-reaching implications. It's also an excellent opportunity, of course, for preeclampsia, which is not today's topic. Beyond that, we don't say that we stop at one anomaly. We must look for other anomalies. We should have very easy access to all the syndromes so that within your office, you know what else to look for and make a complete diagnosis, and that genetics becomes important. One very important factor that has been brought out here is that some manifestations will only be seen at 16 weeks or 20 weeks, or even sometimes as late as 32 weeks. Therefore, serial evaluation is necessary, although counseling for the patient will take place at all times. In addition to this, the very fact that you can see so much more at 16 weeks compared to 12 weeks, whenever there is a doubt and the patient does decide to carry on, then that is the time to make sure that we do a 16-week study with an amniocentesis, although we know that DNA preparations are much better, as Deepanjana told us, at the 12-week scan. But there is so much more that you can see at 16 weeks in some of these that I'd rather wait for 16 weeks. The last step that we must remember to tell the patient is in our counseling that our prognosis will change during the course of the second trimester. Also, that our genetic evaluation will be stepwise. We will initially exclude the common autosomal trisomies, But then we will decide whether we're going to do evaluation of one gene or a few genes, or whether we're going to look for things that might be picked up as in a microarray, or we might even add on as a later step the possibility of an exome sequencing. So this kind of thing has to be explained in addition, of course, to the structural changes that we see, which will change the prognosis at 16 weeks.
Brilliant. So that's why I have added DNA preservation of the POC sample, if indicated, is a good option. Devashmita, you were trying to say something?
I want to ask sir 2 questions. Khurana sir.
Is there any time? Sita? Only
yeah,
one
make it quick,
question.
Devashmita.
Only one
Just
question, please.
Just, actually, there is a literature showing various literatures. The alpha fetoprotein is a good marker for intra-abdominal wall defects. So what is your go on this?
You know, it's very convenient to use if you're doing rushed scans. You're doing 100 patients in 2 or 3 hours, where you might miss something. But the way we're doing our scans today, we don't really need alpha fetoprotein as a pointer for abdominal wall defects.
Brilliant. So I think I shall conclude my session now, and over to Sita, please. Thank you.
Thank you, Pradeep, for that excellent demonstration of anterior abdominal defects. And thank you, Khurana, sir, for your valuable inputs as always. We conclude this session, and may I please invite Dr. Kamal Oswal to give his concluding remarks and end the session.
We had a wonderful academic feast with great teaching points. As we know, first trimester gives us an opportunity to look for clues for abnormalities at a very early gestational age, and gives us sufficient time for counseling, further investigation, and to give time to the couples to take their final decision. I thank all the presenters, Dr. Shankar De, Dr. Khurshid Alam, and Omitra Shudan Rai Chaudhary, for preparing their cases and putting a great amount of effort. And thanks to all the panelists and the experts for their expert inputs, Dr. Ashok Khurana, Dr. TLN Praveen, Dr. Kushagrati Ghosh, Dr. Kanchan Mukherjee, and Dr. Prasanna Rai. As usual, we are thankful to Dr. Ashok Khurana and TLN Praveen for being always there for encouragement for these meetings, to make this meeting successful, and taking time to be there all the time. I wonder at their endless energy. Thanks from the depth of my heart. And we are thanked from the SFM Kolkata branch for their very great effort in making the fetal medicine popular in India and outside. And I am also thankful to the Vishal for his stage work to make the programs successful. And I have seen that the participants are more than 250, and it's very heartening to know that so many people are still there for this conference. Thank you all.
Thank you, Kamanda.
Thank you, I think.
Good night. Really, all of us enjoyed a lot, I must say, and special thanks to Ashok and Dr. Praveen and all of us. Thank you. Thank you very much. Really enjoyed.
Thank you.
And it seems we need a whole day first trimester session coming from Calcutta soon. I think we should plan that. I think between Dr. TLN Praveen and Bimal, they should put all this together, and we should see a full day session coming from Kolkata for a first trimester evaluation. There's just such brilliant images and such brilliant cases. My congratulations to everybody in the state.
Thank you.
Thank you, sir. Thank you.
Thank you.
Sure, we'll make sure it happens.
Yeah. Good night.
Good night.
Good night.